Hello, I'm Dr. Michael Schuler with Athens Orthopedic Clinic. Today we're going to talk about cubital tunnel syndrome. It's similar to carpal tunnel, a little less common and involves a different nerve, but is a similar concept with regards to peripheral nerve compression. What cubital tunnel is your ulnar nerve runs through a groove on the back side of your elbow. It's what we typically refer to as your funny bone. It involves or gives feeling to the small finger and the radial side or the ulnar side, the small finger side of the ring finger. It can get trapped, very similar to carpal tunnel, cause a lot of problems with numbness and tingling. So typically symptoms, people describe their hands falling asleep at nighttime. This typically occurs with elbow flexion. So people putting on makeup, tying ties, anything that really involves elbow flexion can result in numbness or tingling. Again, it needs to be differentiated from carpal tunnel syndrome, which typically involves the other 3.5 fingers, that being the thumb, index, middle, and thumb side of the ring finger. They can come together, and so if people say, really my whole hand is falling asleep, it could be both carpal tunnel and cubital tunnel. If you're experiencing those symptoms, things that can be done, wearing either what I typically recommend is an elbow pad with the elbow pad turned in the front of the elbow to prevent you from bending your elbow at nighttime. You can wear splints. Some people even wrap towels around their elbow to try and keep their elbow straight. If that doesn't work, typically surgery can be performed to release the pressure in a similar fashion to carpal tunnel syndrome. So with cubital tunnel syndrome, we typically get EMGs and nerve conduction studies. Usually the insurance company requires us to do that as well. It certainly helps us with regards to making sure we're doing the surgery that you need to do. I typically liken it to a lamp that's not working at your house. If the lamp doesn't work, it could be something wrong with the lamp itself, such as a problem with your hand. If you've got a numb hand, it could be that you blew a fuse, which would be something in your brain, or it could be that someone was mucking around in the walls and cut the wire that goes to the outlet that the lamp's plugged into. That could be your neck, your armpit, your elbow, anywhere where that nerve travels. If it gets squeezed or irritated, it can make the hand fall asleep, specifically with cubital tunnel, the ulnar side of the hand, but we want to make sure we're doing the right surgery at the right time. What those nerve studies will do is they'll they'll poke you with some pins and needles, shoot electricity down the pins and needles. Sounds like a medieval torture test. It's not that bad. I've had it done to me. But what they're looking for is the speed in which those nerves conduct electricity. If it's slowed as it crosses your elbow, then that obviously shows that the nerve is getting squeezed at that point. So if we perform a mini open cubital tunnel surgery, again, we make a small incision right at the inside part of the elbow. We release from about here to here. You will be sore in those areas. You may be bruised in that area. We typically put stitches underneath the skin. The surgery takes about 10 to 15 minutes to do. You have an ACE bandage that's placed on the arm, from the upper arm down to the hand for 3 days, after which you take the dressing off, you can get it wet, take a shower, and really do whatever you're comfortable with. So if you've heard or read or looked up cubital tunnel syndrome, there can be some scary pictures and or comments about it. Some people end up making very large 10-inch incisions along the elbow, can be placed in even a splint for up to 6 weeks. They move the nerve, and it can be a pretty invasive surgery. Typically I do what's called a mini open procedure, which results in about an inch-long incision, maybe 2 inches. We go in and still release the nerve underneath the skin for about a 10-inch frame, but it does not require any splinting or immobilization. It does not require a large incision in the skin. So typical recovery, my expectation or hope would be as soon as you wake up for surgery, or certainly that evening, you'll start to experience improvement with pain. It might take a long time for that nerve to wake back up. The nerve is being compressed at the elbow. Once the pressure is released, the nerve will reset from the elbow and work its way out. The last place you'll feel normal is at the fingertips. This can take several months for the nerve to wake back up and reset all the way down to the fingertips. Additionally, if you have wasting, which is muscle loss either at the base of the small finger here or at the top of the thumb here, that muscle hopefully will wake back up and start to function again and build back muscle mass, though again that can take months to even years for that to recover, depending on how bad the nerve's been squeezed preoperatively. Things to look out for, certainly post-operatively, the nerve can sometimes scar in, sometimes a larger incision and even wrap in the nerve after or during that second surgery is required. This can happen approximately 5% of the time, but can certainly happen. Additionally, the nerve sometimes can snap or become unstable and snap over the corner of the elbow with elbow flexion. If that occurs, again, sometimes it is required to repeat the surgery and move that nerve to the front of the elbow. But again, these are fairly rare and don't happen very often. So with peripheral nerve compressions, similar to carpal tunnel syndrome, we don't encourage people just to grin and bear it. Nerves are like fiber optics. It's one big tube with a bunch of little bitty tubes running down the middle. If that big tube gets squeezed, it can start to pinch off those little tubes. If those little tubes get pinched long enough, you can get permanent nerve damage. When we go in to release the pressure on that nerve, all we're doing is releasing the tissue around the nerve. We hope and expect that nerve to pop back open, but if we go inside the big tube to mess with the smaller tubes, we just create scar tissue and more problems for that nerve. And so ultimately your nerve has to, or those small tubes within the outer tube have to pop back open on their own. The longer they've been squeezed and the more compression they've experienced, the less chance they have of opening back up. So hopefully you've learned a little bit about cubital tunnel. I'm certainly happy to discuss any further questions with you.